All right, everybody, welcome back to another edition of Bulletproof Dental Practice Podcast. Today, we are excited to welcome back the legendary, the one and the only Bruce Baird. And we've had Bruce on a while back. What was it, Craig? Probably 3 months ago, 2 months ago?
Yeah, a little longer than that.
And it was, and it, without fail, one of the most popular podcasts we've had to date. And so we decided we'd double down on that and get him back on. And today we're going to kind of go a little bit more granular. We're going to use his power and his focus and his wisdom and distill it down to the top 3 things we think you need to double your production. Isn't that right, Craig?
Yes, sir.
Craig
Bruce,
is
so happy to have you here.
Craig has his pen and pencil ready, Bruce, as he's going to be a student, not only as am I. Craig, don't worry. But Bruce, welcome back, pal. Welcome back to the show.
Thank you, man. Thanks for having me back. I appreciate that. Yeah, I'm excited to talk about productivity, since that's kind of what my brain does. It thinks productivity all day, so it's kind of good.
I remember literally, I don't know if I gave this anecdotal story, but I remember the first time being exposed to you as a young pup. I remember listening to you speaking. It was somewhere in Texas, I think. And I remember you talking about stuff, and I was like, what? How does someone do that much per hour? And, you know, and it's like, there's no way, this is scammy. And then you kind of broke it down, like, you know, you're forgetting about all the occlusal, you know, I think the thing that stuck out in my head was like the incisal attrition that happens on people with wear, and like just going in and doing 6 anterior, like rebuilds of that takes you an hour and you get to charge, you know, amazing stuff. And the patient thinks you're a hero. Like that was the one thing the one takeaway. And I was like, holy shit, you know, or just like breaking out a diagonodent, you know, and being like, oh, there's an occlusal composite that takes 5 minutes to do.
That's right. That's
you know,
right.
So
it's funny. People always want to know what's the magic formula for increasing productivity or doubling productivity. And I break it down into probably 3, and there's some others, but probably 3 main areas. But the thing to know is there's no silver bullet. I mean, we think, oh man, if we start doing Lanap surgery with a laser, we're going to immediately go to 9,000 an hour. Or if we start doing implants, we're going to start doing this. It really comes down to what are we doing per patient, you know, on a day-to-day basis. And if you want, and I see this day in and day out, you know, working with dentists all over the country, but it's like they don't, you know, their hygienist sees their new patients, which my recommendation is, hey, if you're going to be a full service dentist that's going to be well qualified, well trained, and know a lot of different things, I mean, you want to see the patient first. You want to get them, you go through their risk factors. And the comprehensive exam is, to me, the number one thing to increase your productivity, or to double it or triple it, is doing a comprehensive exam. And when you do a comprehensive exam, it's actually fairly easy. You just ask permission, you know. Now, if a patient comes in with a swollen front tooth or whatever, a toothache, that's not going to be that's your periodic oral exam or whatever. But when I'm talking about new patient coming in, how do I double my production? That's how you do it, is doing a good comprehensive exam. And I'll have people that come in and say, I'm really concerned about these 3 teeth. And I will always say, well, is it okay with me if I take a look around the mouth totally? And they go, yeah, that's fine. And I said, but I'm going to make sure that we take care of these 3, obviously. And then all of a sudden I go into my new patient exam, or my exam process, which is literally going through risk factors, the John Kois's risk factors, periodontal risk is always first. I tell the patient, if you have, we're always going to check, make sure you have a good foundation. And then I tell them about their foundation. And I said, and then we look at decay or erosion, cavities. Do you take meds? You know, they go, oh yeah, I take 50 meds. I go, oh yeah, see, there you go. And so we go through that. So it's a comprehensive exam. And then,
Bruce, can I interject something here? How long does it take you? Obviously, you've done 1 million comprehensives at this point in your career, and you've dialed it down, distilled it down, gotten it perfected. How long do you think it takes you on average to do that?
20 minutes.
20?
20 minutes, no matter how complex the case is. Yeah,
that is good intel.
There's 2 types of people, though. There's engineers and there's non-engineers.
Right.
You know, the old engineer, you know, I may say, you know what, you know, let's do this. Let's get some models of your teeth. Let me study your case and let's get you back in.
Mm-hmm.
That patient's asking every question on the book. So yeah, there's some times where you just have to, this person's not going to be able to pull the trigger unless they have all the info. Whereas 80% of your patients, if they like you, they're going to do the work.
Right.
You
Because
can
they
find
trust
a way
you.
for them to do it and find a way for them to afford it. It really comes down to the comprehensive exam and likability. You know, if I used to tell one of my associates, I said, dude, man, just smile.
Yeah.
You're so serious, man. I wouldn't buy nothing from you. I mean, this is freaking, you
You-
come in like, yeah, okay, well, let's look. And it's like I don't know. I want
Hey,
to be
Bruce,
yeah.
what happened to that associate? Did he last?
No. He's, buddy, I'm sure he's doing well somewhere else. So that was,
How long did he last in your office?
he was there for probably a year, year and a half. And then
It's interesting. Sorry, go ahead.
No, and then he went and opened up his own practice. And I've had a few of those that come in, and I tell them, just learn to communicate, match and mirror, go through, learn some neuro-linguistic programming.
There you go.
Look, there's plenty of books out there you can read.
Craig and I talk about that all the time of like people say like, what do I need to do? And like, you need to go learn public speaking. You need to go NLP. You need to learn body language. You need to be able to, like, just like you said, you identified with this, you had enough self-awareness to identify this person's an engineer. This person's, happy-go-lucky. This person, like, you can curate your presentation, and the best dentists do that.
They do.
I want to just put a small pin in this right now, because Bruce is between the three of us, we have so much experience with associates, and everybody looks at, I think the average dentist that bring in an associate really overvalues the clinical skill set that they have, the training, the courses they've gone to, and undervalues the emotional intelligence and communication skills. And we all know you could be phenomenal. You could literally be John Coyce, and you could completely nosedive if you don't have that communication skills. So my question to you, Bruce, is when you've met those doctors that have worked with you, and it's more of a communication / character thing, have you recalled a specific instance where you were able to successfully groom that person and make them better and have them laugh?
Are you born with it, or is it learned? Can you groom someone?
You can absolutely learn it. I mean, there's no question about it. It's kind of like saying that, it's a one-act play to me. I mean, you just change the lines, and so I'm going to get on and I'm doing a one-act play to an engineer. Now I'm doing a one-act play to a person. Now I may be somebody who is much more like an engineer as a dentist, so I can talk to people in engineer language. I didn't know I could, but I can, and I get frustrated with, because we opened up and had a jillion new patients, and we were right down the road from a nuclear power plant with a bunch of engineers.
Right.
And they're asking the molecular structure of titanium. And I'm going, dude, it doesn't make a damn bit of difference. These, and they would be like, oh, well, but I had to learn. I had to learn to speak engineer. And then but the problem is you've got 80% of the dentists out there that are engineers. I mean, that's the way we go to dental school. And every step has to be done perfectly.
And Bruce, would you also agree that, sorry to interject, but would you also agree that dentists, when they get uncomfortable, their default is to go technical?
Oh,
of course.
Yeah.
Oh my God, that's where they're comfortable. That's kind of like ask any dentist, and we're all the same. I'm most comfortable in the operatory, no question. That's where I'm comfortable in the op, but that's the least comfortable place for the patient. It's why when a dentist is walking down the hall and a patient meets you in the hallway, and the dentist will go, "Oh, hey, how are you? Good to see you." And they back against the wall because they're freaking out, because they know the patient in the op, but they don't know him in the hallway. So pretty sad.
So true. It's like, wait, what are you doing out of your habitat?
Patients will say to me all the time, like, God damn, you're tall. I'm like, I'm 6'5", but they never saw me like outside the chair. Like, I'm only 14 inches taller than them in the chair.
That's exactly right. But yeah.
So wait, could this be number one then? I know we just like rambled right into this, but could this be like your top one, your number one?
There's no question. If you can learn to communicate, you're going to increase productivity, as long as you're doing a comprehensive exam.
Okay.
If you're just looking in the mouth and saying, and we've been groomed as dentists across the country by insurance companies to think that, well, they're only going to do one crown at a time. And truth is, 95 crowns out of 100 are done one crown at a time now in the US. Why? Because tell them they need 4. they ask you, will my insurance cover? And you say they'll cover a portion of it. And then your team comes in and says, your portion is going to be 3,500. They go, well, I can't afford that. And then, so now we get groomed into, just after you've been turned down for 4 crowns or 5 crowns or whatever it is, a more full exam, all of a sudden you just come in for every new patient. You're just going like, this is the worst. Let's keep an eye on these and let's do number 19. And that's your lower left molar. And I'm going to tell you all about, how the nerve goes into it. And I'm going to bore the shit out of you until finally you're going to do it, or you're going to leave.
Or I'm going to untalk you out of what you already agreed you said you'd do.
That's right. Yeah. That's right. And I'm a prime example. I'm a prime example of this. I go to a car dealer, and if the car guy said, just sit down, I just know where the gas goes, and I know how to start it, and I know how to drive it, and I love cars, but I'm not into the engine and anything. And the guy gets opens up the engine and starts telling me, now see, the Mercedes doesn't have this, and this is the only car that has that. Pretty soon, I figure I am so freaking stupid about this. I can't make a $80,000, $100,000 decision. So I go, let me think about it. Let me go home. Well, it's the same thing when you're doing comprehensive dentistry. When you start explaining all this crap, unless it's an engineer or a pilot.
It's an engineer, exactly. Yeah.
Unless it's an engineer or pilot, you're going to be fine there. But with the average person, if they like you, they're going to, they're going to say, yeah, let's do it.
Yeah. Show the problem, show the benefit, and then shut the hell up.
That's right.
I like
Tony Robbins talks about verbal vomit. You just keep talking. The patient glazes over, and pretty soon you're done. I mean, now it's usually what you do is you go to the smallest common denominator. Let's get your teeth clean, and then after that, we'll get back and we'll take a look at things, because you just want to get the hell out of the room because you've just puked all over them.
That's the layup, right?
Yeah.
So you grew up in the era, and I don't hear about it much anymore, but I grew up in kind of the Paul homily era. So I'm looking for sources or resources that you could recommend to those of us who need a little bit more help. And I remember Paul being awesome, and I don't hear about him much anymore. I don't know what he's doing. Maybe he's enjoying his time on the beach with the corona, but he was a master at his verbiage and just like training dentists and such. So do you have one that you would recommend some of our listeners kind of either read, book, or listen, or watch YouTube or whatever?
I know Chris Phelps does a lot of stuff on,
NLP
influence, and so I think he is good. I mean, Paul's still out there, and I learned a ton from Paul back, Paul and I have known each other for 35 years. So it's, I learned a bunch from him.
Me too.
There's, I know at Productive Dentist, we teach, that's one of the things we teach.
Okay.
Communication skills. It actually is one of probably the most important things that we teach. We actually spend a couple of hours actually role playing and going through with the doctors.
Yeah, I know Vicky really loves that stuff too, I mean, as you do, right? And so she's a master as well.
She is. And so those, I mean, and pick up books and start reading. That's what I did back in 84, 85, because I couldn't communicate with these engineers. And so I started becoming an engineer when it was an engineer, and I was more myself when I wasn't. So it was easy, but it's out there.
Yeah.
There's books on NLP.
Cialdini. Are you a fan of Cialdini? I know Chris Phelps is. Okay. Yeah. That's a great author to check out. All right.
That really is.
Let's pivot. Craig, what would you guess number 2 would be, Craig?
Not
to steal Bruce's thunder at all, but I'm
gonna have to say that, listen, I always know the trifecta. You need to have good hand skills, you got to get people to like you, and you got to see the problem. So I'm gonna say diagnosis, seeing the big picture, seeing more than just the tooth, seeing the mouth.
There's no doubt about it. I mean, it's funny. We go through our exam process, and for the first, when we're going through risk factors, we're not going through the teeth individually. We're going through the entire mouth and coming up with their periodontal risk, their decay risk. And we're finding out, hey, you're on 9 different meds. That steers my treatment plan. And so if I'm sitting here and I have a patient who, comes in, they've got a mouthful of stuff that needs to be done. I mean, a mouthful. And because I market to train wrecks. I mean, that's who I want to come in my office. I want train wrecks coming in. I don't want mom and dad with 3 kids. It's just not the kind of practice I have, because that's not what I do. But I have that patient come in, and I tell them, and I use this line a lot, almost every single patient. I go, you're kind of at a Y in the road. you know, and I point this like, you're at a Y in the road. If you go this way, well, you're not going to have teeth. It's pretty much straightforward. You know, you're drinking Mountain Dew all day long, and you know what God gave you didn't work. And so my suggestion, if you're going to continue to drink it, is let's find some implant related treatment with something that's not going to decay. So if you spend your money, what I don't want you to do is waste money in our office. And I said, but now if you want to quit drinking that stuff and you promise yourself that you're going to quit drinking it, you don't have to promise me. But if you really say, I want to keep my teeth, then you're going to have to start using carry-free rinses. You're going to have to use maybe a fluoride appliance. You're going to have to stop drinking those drinks. Or what I do for you is going to fail 100%, and it's going to go quick.
That is so important. That is so important. I hope everybody just let that sink in, because I think one of the issues is that in dentistry, we identify with the problem. In medicine, I always say this, that in medicine, it's like doctor talks to the patient, says, Joanne, you got cancer. You and cancer, I am going to help you and I'm going to try to beat cancer, but the cancer is yours. But in dentistry, so often we're like, Diane, you got TMJ. I am going to fix your TMJ. I'm going to take it all away from you. You can't say that. TMJ is too multifactorial. There's so many facets to TMJ. You can't say things like that. So I love to when a person comes in and they're a train wreck, they told you it's because they had a baby. Baby took all my calcium away, or something happened. But that's just bullshit. They got there because of neglect. And dentistry is not expensive. Neglect is expensive, and it's going to get more expensive if you do all the work and they don't change the behavior. So if you don't tell them that why in the road and say, I can fix it, but if you don't change what got you here, all my stuff is going to fail. And you're going to be mad as hell at me in 10 years, but it's not my fault. It's going to be your fault. And they'll remember that conversation. But if you don't have that conversation in 7 years, all your crowns failed. No, my crowns didn't break. They think that if you put a crown or something on the tooth, that it's just, they need less dentistry. I always tell them that if you get dentistry, you need more prevention. Right. The least prevention you need is when you have your own teeth. But the minute I start doing dentistry on you, you need actually more.
I always give the analogy. I'm like, see, this is my part. This is your part. If this fails and something under this fails, it's not the dentistry that fails. It was the pen part. Right.
I have all caps. I don't need to go to the dentist anymore.
Do I still have you gotten that question? Do I still have to brush with all these?
I know. Now you're good. You're good.
Yeah. Right.
We see all kinds of stuff. So it's obviously getting patients to understand. One of the things we do at PDA, and actually the first hour when I'm lecturing, is I have everybody in the room say together in unison, it's not our problem. And we go, it's not our problem. And I said, no, you got to really say it's not. So I got the whole room going, it's not our problem. And I go, whose problem is it? And then they go, it's their problem. I go, good. Now you're going to be a productive dentist now if you keep this up. So, because if you take responsibility, and I did, obviously for probably 20 years.
I did too.
I'd replace anything because I thought it was the mesial buccal margin I didn't have perfect. That's the reason it failed. No, it failed because they're drinking Dr. Pepper all day long. It had nothing to do with, the margin.
Just full disclosure, Bruce, Dr. Pepper and Mountain Dew are sponsors of our podcast.
Absolutely awesome, man.
I'm kidding. We take no money.
But they pay really well.
I'm thankful for both of those companies, actually.
Exactly.
I mean, people like it, that's fine. So go for it.
I'm kidding. We take no money. That was so funny.
I get the deal. We live 40 miles from Dublin, Texas, which is the original Dr. Pepper bottling plant. So it's, we got people pure sugar cane, and they go, and I ask them, I say, hey, how much Dr. Pepper do you drink? And they look at you like you're,
how did you know that? Are you watching me?
Whatever. You're like, oh my God, he knows I drink Dr. Pepper. I go, yeah, well, how did you know? I said, well, your teeth are black. And, that's a dead giveaway. So it's one of those things, okay, there you have it.
So Bruce, do you have a structure? So you mentioned, I'm going to go back to the 20-minute exam you do. Do you have and I don't know if you said 5, but like a 5-part kind of exam where you look at these 5 things, or am I just dreaming that you said that last time?
I go through a process where I basically, first I work on rapport, just asking the patient questions about where they live and how long they live there. And I find 3 things, what I call linking. I find 3 things to a chain that can't be broken. And what that means, I know you, you know me, Then I say, is it okay? I'm going to take a look at your x-rays. And I always say the same thing. I say, I could have 10 of my buddies come in here. We can give you 12 different opinions. And which means there's no one way of doing anything. And I want them to understand that, because people
You
come
say
in
that with every appointment and every exam?
every appointment. I
Ah,
say,
I do too. I say that you ask 10
yeah,
people what to do here, you get 10 different answers.
that's right. And so what I do then is I look at their x-rays. I've already been looking at them smile and everything else. So I pretty well know their risk factors. I lean them back. I look in their mouth, literally with a mirror. And then I go through the risk factors with them. The risk factors take 3 minutes to go through it. But I go, does that make sense? Every time I go through that, and they go, oh yeah, but I haven't looked at I haven't talked to Summer, my assistant, and said tooth number 2 needs this, 3 needs this. I haven't done any of that. We may have a $20,000 treatment plan. We're not even to the point of talking about teeth yet. We're talking about they do need Lanap surgery. They've got decay issue. They've got, all these different things that are going on, and that all leads to treatment. I set them up. I lean the patient back, look at their risk factors, set them up, talk about risk factors. And then I ask them, does this make sense? Every time they always go, why hasn't anybody else ever talked to me about this? Because, and I tell the patients a lot of times, not every time, but I'll say, a better question to ask your dentist would be not, can you fix it? Because we're engineers. We're going to say, sure, we can fix it, or no, we can't. But a better question to ask a dentist is, can you fix this tooth where it would last the rest of my life? Well, that's
what caused it? What
that's
caused
going to be
it?
a whole different conversation. And now all of a sudden I'm going, and I tell the patient, and they go, yeah, why has no one else talked to me about this? And I don't throw anybody under the bus. What I say is, you know what? We have learned so much in the last just few years. So what anybody else does doesn't matter to me. I don't care. All I care about is guiding them today. And then what I'll do is I literally will say, if it's okay with you, I'm just going to lean you back again, and I'm going to call out some numbers and letters. Don't worry about it. We'll talk about it when we get done, but I'm just going to talk about the teeth individually. The patient goes, oh yeah. So, and a lot of times they're calling me by first name, or okay, doc, or whatever, because we linked and we know each other. And so I lean them back, and I'll go, tooth number 2, 14, whatever, those need all ceramic, which just means we're going to make EMAX crowns on them. I'll say MODFLs, those are going to be onlays. I say OLs, those are going to be composites. And I don't do them 1, 2, 3. I just call out, they need these numbers with this, these these teeth are going to need MODFLs, and these teeth are going to be OLs.
And you're calling that, and your assistant or hygienist, whoever's writing it down, right? So tell me the logic, or tell me why the 2-part, meaning the 2-part, lay you down once,
yep,
put you back up, have rapport, explanation, lay you back down.
Yep.
Tell me why you obviously learned that to be effective. Can you elaborate?
It's actually massively effective for, we've got probably 1,500 to 1,800 docs have been through PDA. What I found was, by first of all, rapport, getting to know the patient, then leaning them back, and then leaning them up, and talking about risk factors, it gives them the thought process that, well, he's looked in my mouth. If I just went and started talking about risk factors without looking in the mouth, which I could, all I got to do is look at the x-rays, pretty much look at their smile.
Pictures,
I can tell you, yeah, you got perio, yeah, you got this, but I want to go through that little conversation. I've actually looked at your x-rays. I've actually looked in your mouth. Let me talk about this conversation. It's about your problem, not mine. I don't say it that way, but it's about what's going on in your mouth. It's about risk factors. The risk factors are because how long do you had your teeth cleaned? It's been 10 years. Okay, well, that's going to cause problems. And so I go through that, and then I convert back. Now they are totally comfortable because no one has ever done an exam like this on them, ever. And so then I go, all right, let's do this. Let me just lean you back one more time, and I'm just going to go individual tooth by tooth and talk to Summer and tell her. One of the other things that I always do is when I finish, I go, do you have any questions? And they'll say, no one's ever gone through stuff like this with me. I don't have any questions. I understand it. The thought is, I want you to do it. Are you going to be doing all this work? Yep, I'm going to do it all. Okay, I just want to be sure. And then I said, let's do this, because everything comes down, to time and money. I said, I'm going to have Summer. She's been with me forever. She knows this stuff forward and back, and she's just going to help you get this done. And that's the end of my deal. I walk out of the room.
Oh.
Now, One thing I do, go ahead.
No, please.
No, one thing I do, which if it's a big case, like I'm going to say a big case is maybe more than 10,000. Okay. I'll say, Craig, I know you probably already knew this, and I'm nodding. And the patient always nods.
I'm nodding with you right now, actually.
And I say, I know you probably already knew this, but you probably have $18,000 to $20,000 worth of damage in your mouth. And they're going to say one of three things. They're going to say, yeah, I knew it, you know. So that means let's get it done. They already knew they had a bunch. I'll have people say, well, yeah, I knew, but I didn't know I had that much. And I go, how much do you think you had? Oh, I thought maybe 10 or 12. I go,
wow, brilliant shit right here.
It really is. Like, this is like.
Sorry, I try to give you some. Yeah, go ahead.
No, well, they'll say, well, you know, I'll say, well, you can use that 12. We'll use that as a down payment. And then we've got convenient monthly payments. We can work the rest out. Or they'll say, oh, hell, there's no way. I got 5 kids in college. I mean, there's no way. Okay. Before I leave the room, well, let's come up with another one of those options. So and I'll just very simply say, we're going to do, we got to get you in the perio first. We got to get you using Carry Free. We got to get you to stop drinking the sugars. And let's do these 3 worst teeth. But almost every patient does work. And that's why this past year, I mean, we've been able to produce just under 4,000 an hour. So it doesn't take, that's a lot of dentistry, no question. But when you're doing it the way we're doing it, it just makes sense.
There's a couple things that I just want to jump in on. So what you've done by having that conversation, I love how you say you've got $18,000 to $20,000 worth of damage. Okay, so it's not dentistry. It's not you need to buy $20,000 worth of stuff. You've got this much damage. So it really, it's a subtle nuance, but it really shifts the responsibility to them. They have damage. And also what you've done is you've not allowed a treatment coordinator to get involved just yet. Because if you don't have that conversation, oh, hell, no way. I got 5 kids. I don't even have $1,000. Imagine if they go to the treatment coordinator. The treatment coordinator is like just fumbling. Patient's walking out the door. So you let Summer know, hey, Summer, he said no issue. I figured as much. So just get the treatment plan going. Or you just have so much intel there. The other thing I love too is early on you pointed out, I just want to reiterate these points because they're subtle and maybe people are, not glazing over some of this. So that's one thing. The other thing is that you pointed out that a lot of dentists were engineers, so we fixed shit. You got a broken 30, we fixed that. But if you start looking at the cause of the problem, now you get into comprehensive dentistry. You go from tooth to mouth. Right. So why did 30 break? Yes, it could have been the little pebble in the salad, and that happens sometimes. But more often than not, dental disease is biomechanical. There's biology and mechanics. And if you fix just the biology or fix just the mechanics, it doesn't work. So when you can have the conversation of, yes, Mrs. Jones, a couple teeth are broken here, but can I talk to you about why this happened? Because Dr. Jones, he's a great guy down the street. I'm sure he meant really well when he fixed this tooth 2 years ago and it broke again. But he was, and you said, listen, we have a lot of, you're trying to skirt around, why am I seeing it? Why the other guy not see it? Dr. Jones was just interested in fixing what he saw. But can I tell you what I'm seeing? Because there's a bigger cause to this. And doing the same thing over and over again and expecting a different result is the definition of insanity. So if you allow me to talk about the cause and what's going on at the holistic level, we're going to get further ahead. And I think that's what allows the conversation of mouth dentistry versus single tooth.
It does. And to me, it's a huge part of being productive. It's a huge part because the most frustrating, and I think one of you guys mentioned it earlier, is the most frustrating is having somebody who's been through all of COIS or been through all of Spear or LVI or Pankey or, I don't want to miss anybody, but I mean, they've been through all the courses and they're floundering. Those are the ones I love to help because they already have all the skills. They just need somebody to dance with. And, and by learning to communicate, that does, to me, that makes the difference.
But also too, sorry, Craig, but having that that conversation of asking permission and having a global diagnostic conversation, right? As opposed to getting nervous and going for the layup. Oh, that tooth's broken. Let me just get this crown on the schedule and leave the room.
Right.
Right. You are sticking in there and not only leaning them back once, but leaning him back twice and asking permission all along the way and building rapport, which that's like probably the most powerful 20-minute exam of comprehensive exam I've ever heard. And so I know I'm going back to the 2 times, but because I'm just mesmerized by that. And like, obviously you have data on the 1-time lean back versus the 2-time lean back kind of thing.
We do. I mean, from an increase in productivity, we also have data on new patients going through hygiene first. I mean, increase your productivity by 37% just by not having them go through hygiene. We know that you're gonna actually treat.
Wow.
It's what we call 3-to-1 ratio. You're going to diagnose 3 times what you're actually going to do. So if I diagnose 300,000 in a month, next month I'm going to do 100,000 of it. I mean, are all patients accepting? What's your acceptance rate? That's the biggest farce in dentistry. What's your acceptance rate? Well, if you're only telling them they need 1 filling, and you have 100%.
100%.
So going, well, it should be.
What do you like to see your team and your clients do?
It's all about how much do I diagnose, and I know I'm going to do. If I diagnose 300, I'm going to do 100 next month. If I do 500, I'm going to do, whatever it is. And I diagnose a lot of dentistry, and I only see 20 new patients, but 20 new patients times 20 grand each. I mean, I've got $400,000 worth of treatment plans. I know I'm going to do 140 before I even start seeing my hygiene patients or anything else. So it's always, we track that. I mean, we track it every single month. Jeff, my partner, last month diagnosed over $1 million in dentistry, and he saw quite a few new patients. And I was like, whoa, you diagnosed $1 million. That's crazy.
That's a cool metric, and no one talks about this. So can I want to put a pin in this?
Yeah, that's important. I was just having a conversation.
Everyone focuses on how much they produced or how much treatment was accepted, but like the real number, the real conversation would be, how much did you diagnose and present?
Yeah.
That'd be cool.
I was having a conversation with my doc. So like my acceptance went up from 30 to 36%. I'm like, yeah, but you presented in January 297, and in February presented 200. So you actually lost.
That's right.
So it doesn't matter. I'd rather you get 10% acceptance and diagnose 3 million than have 90% and present 50,000. But I want to point out one just quick thing, because I'm sure some people are listening to this right now and saying, talking a lot about money, talking about enrolling patients, and I'm not interested in money. I'm just interested in taking good care of my patients. And I want to challenge people, because we're all presuming. Listen, Bruce, I know you well enough to know you're an extremely ethical dentist. I know Pete the same. I can speak on behalf of my team. We're doing what's right for people. Who wins when a patient gets the work they need done? Is it really the doctor?
The patient.
And I want to check. It's the patient that wins.
Yeah, exactly.
Because if you're diagnosing MODs and inlays and crowns, we all know if they don't buy it now, even the person that can't afford all the work, if they don't do it now, we've all seen patients that had, $2,500 worth of fillings to do or a couple crowns, saw them 6, 8 months, 10 months, a year later, and everything is totally fucked. Root canals, exos, implants. So it's like, you got to get out of your head. This is not about you. It's not about you saying I'm doing this much money. It's about who you serve. And money is just a lagging indicator of helping people. It's a virtuous cycle.
It's interesting. People ask me a lot, if you have a dip in productivity, what things do you look at? And I said, it would be easy for me to say, well, I'd go to my team and say, all right, we need to get more crowns out of hygiene. We need to get more of this. We need to do more of that, and get all pissed off. And, like I used to do 25 years ago. And instead, when I wasn't diagnosing a lot and I was going, we need more production. Well, you need to diagnose more. But I'm sitting here and they said, what do I look at? Well, what I look at, do I remember the new patients I saw this week? Do I remember their names? Do I remember them? Do I remember the linking we did? Am I taking great care of it? And did I recommend to these patients exactly what I would have done in my own mouth? And if I can say yes to those, and if I can say no, and sometimes I will, I get on a roll and I'm just like, I think I don't have to do the layback. Summer, one of my assistants will say, you didn't do the risk factors with them. I go, yeah, I did. They go, no, you didn't. And I was like, okay. And she's right. I think, well, anybody that I talk to is going to say yes. And I quit doing the things that made people say yes. And And so, and a lot of that is getting to know the patient and doing those things. So it's not about money. It's always about relationship.
And it's not about yourself. It's about them.
Yeah, it
Sorry,
is.
Bruce, I stepped on you.
No, it is. It is totally about them. And if I just, and it's their problem, and I'm here as your consultant, I'm going to help you. They say, well, I rarely ever, I love second opinions. I saw a thread online that, oh, these people were saying, oh, charge them. You're a dentist. People won't, you know what? I'll do a second opinion at no charge. Come on in. I don't care if I take x-rays. I don't even care if I take a scan, because if you give me an opportunity to link with a patient and get to know them and get to know our team and our office, they're going to have it done in my office.
You're going to win, right? And that's a winner's mentality, though. Like, give me the shot, and I'll win. I love that.
And we're going to be 30% more expensive than the last guy, which is the reason you left, to have a second opinion, and that's okay. Patients go, whoa, I didn't know. That somebody told them it was going to be 10, and they wanted to find out if you were going to be 8, and instead I'm 14. But they do it because now they understand why.
And you created that value and that relationship.
Yeah. Exactly. So that's big.
All right. So what would be a third? I always stay very tactical, Bruce, very strategic. So what would be the third thing that you see as that one of the top 3 reasons of how to double production from dentists that you've seen?
You have to make it affordable. Now, what does affordable mean? People don't think this way. There's not, the financial arrangements that dentistry has had for the last 39 years that I've been doing dentistry are the exact same. It's cash up front with a discount. It's third-party financing. We're going to take a 10% haircut, or pay a third, half or half. It hasn't changed. And the consultants keep spewing this out because third-party financing has got them trained, and they pay for them to go to all these nice meetings, and they give them $5,000 for every meeting they do. And so they teach these people to say, well, we have interest-free financing for 12 months. Well, what you're doing is you're telling your patients who have money that you're going to take 10% off so that they can pay somebody else 12 months of interest-free financing. And I look at that and I go, that's the stupidest damn thing I've ever seen in my life.
I do it all the freaking time.
Me too.
So stupid.
But we do it because we've been taught to do that. And our team has been taught by third-party financing to use that as an option. And okay, it's an option. If you're in practice, you need to have cash, but that's where making dentistry affordable, which most people in the United States, the average amount of money that's in the bank, they have $4,000. That's the average person. And you give them a $12,000 treatment plan. That's what they have in savings. And they look at you like you are nuts. Or they have credit card debt, $18,750 going up by $250 every quarter. And now, and so they're in debt. And the majority of people have a lot of debt, and you're trying to tell them they need a lot of dentistry. But they've learned and they've been taught American way. If I could make monthly payments,
the monthly economy, yeah.
I can, most of us would not be driving the car we were driving. If they told me I'm going to drive this, Lexus LS460 with all the gear on it, and it was going to cost me $100, and I say, well, and I had to pay $100, I'd go, well, what else can we take off of it? All right, I might pay $70, but I'm not going to pay $100.
Right.
Well, but if they told me it was going to be $1,100 a month, I'm like, dude, bring it down. I just trade cars every 3 years. I know I'm getting hosed on my lease. I don't worry about that.
And that mentality, the car industry has figured it out. Like, no one said at the core is like, okay, it's $70,000. How would you like to pay? Check or credit card? Right. Like, they figured that out. And I think our economy is going that way. That's why like SaaS products have the multiple massive valuations, because they figured out, like, don't charge this much for the software, just charge, the monthly recurring, right? So
don't get people no attrition.
It's this monthly subscription economy / thing. And so dentistry hasn't figured that out, but as well. Sorry.
That's really
I have something I just want to share. It's too good not to share. Imagine if you called up your cable provider, said, hey, you want HBO? Yeah. Let's get HBO. You want to add Showtime on that too? Yeah, cool. Yeah, Showtime. That'd be great. All right, we got a package for you. It's $18,000. Well, what do you mean? Well, it's a 10-year package. It's going to be the next 10 years of cable. Because if your cable bill is 150, and I know for many listening right now, that's actually low. But over 120 months, 10 years, your cable's actually cost you 18,000. If your dentistry only lasts 10 years,
Yeah.
it would be less than your cable bill. If let's just say all those treatments you're talking about, the 12 and 18, say 18,000, it's going to be $18,000. Just want to let you know, if you think your cable bill is going to stay the same for the next 10 years, probably not. But let's say it did. And your cable is going to cost you 18,000. Your haircut's going to be 12,000. Your wireless bill. People don't. The problem is dentistry should last for 10, 15 years, but we have to pay for it all today.
Yep.
But
Yep.
they don't see the recurring costs in their life like that. But
No, I mean, that's perfect. I love that.
So what are the solutions to the way it's always been then, Bruce? Like I know, yeah.
Well,
Talk to us about.
Compassionate Finance has been around now for 8 years, and a company I started, and we've done $250 million in notes now for dentists. It's not our notes. We basically service the notes that the dentists have. So instead of taking 10% off of people who could pay you anyway, taking 10% off your treatment, you're making 9% and 9.9% interest. If you take our stuff off, what the company charges you, you're making 3 or 4% interest, but you're making 10 extra. So you're making an extra 13% on that money. So, and the average across the nation for compassionate finance interest is about 13.9. So if you figure that, you're making 7% interest plus not giving up 10, that's 17. And that's yearly, and it's big money. It's the first time ever that a dentist has literally been able to do $1 million worth of paper notes that are high value, short duration, and it's your note. And you can do $1 million in 2 years. I mean, whereas dentists are wanting to spend 35 years in practice and 40 years and hoping that they can sell their practice for 400,000, and that's their only retirement plan.
I love this.
To do the dentistry. And
I love this.